So this is week 5, part 2, and we're going to talk a little bit about mental health and aging and how mental health impacts older adults. So we know now that cognitive changes are not a normal process of aging. It's no longer expected that all persons who have become older will eventually get dementia. And it's kind of funny to think about it, but at one time that was the expectation. We do know that there are some very specific central nervous system changes that occur. So certain parts of the brain shrink. That's normal due to aging processes. We know we have fewer and smaller neurons, that our dendrites shorten and those branches decrease. So we have fewer branches and we have a lower number of synapses. But because we shouldn't expect that all persons get dementia, we want to think about what are the signs of normal aging compared to the signs of an altered cognitive process. When I say dementia or Alzheimer's disease, I'm talking about, in this general term, about lower cognitive processes or cognitive decline. So in normal aging, we'll have someone who occasionally forgets, who sometimes makes a careless error, who might forget what day it is and then quickly remember, who could have vision problems due to cataracts or glaucoma. They occasionally forget a word. I mean, we do that now, right? Where you're like, oh, I know what the word is, but I can't pull it out. You lose things, but you're able to stop, think about where you went, and go back and find it. So you can retrace your steps to find that item that you set down. Like you put your car keys down in the bathroom when you threw the laundry into the dryer quick. You might make a poor decision once in a while. You might sometimes miss a social or medical appointment, and you can become irritable when your routine is disrupted. Those are all normal parts of aging. When it becomes a problem is when we start to see that this cognition is declining and the person is struggling in their day-to-day activities. Some signs of that is that the memory loss disrupts their daily life. They routinely have difficulty solving problems using numbers. They can't remember things like how to write the check, how to turn on or turn off the stove, which could lead to fires, right? They can't do daily tasks such as driving or managing finances. They have trouble with driving because they end up getting lost and they can't figure out how to get home. They become confused about dates, seasons, passage of time. So this is when they'll say that it's Christmas or it's 2006. They'll have a total disruption about that time frame change from what it is now. They'll have trouble reading. They may have trouble differentiating between colors or judging distances. They often use the wrong word or forget a word. They lose things, but they struggle to retrace their steps to find them, so they can't figure out where they left them. They don't know where they were 2 minutes ago. They consistently use poor judgment, and they become confused, suspicious, depressed, or anxious, and these are new behaviors. It's important that you're able to tell the difference between normal aging and something indicative of dementia or Alzheimer's disease. We'll talk a lot more about dementia and Alzheimer's disease later in the semester and some specifics about them. But for now, I need you to think about what would be considered normal and what would be considered a problem or indicative of dementia or Alzheimer's disease. And basically, normal aging is those occasional things. And something indicative of dementia or Alzheimer's disease is something that disrupts their regular life. It's routine. It's becoming a problem frequently. It's a consistent problem. For the cardiovascular system, we want to think about some of these changes too, because all systems age as we grow older. And when we are younger, our heart looks pretty healthy typically. We have cardiomyocytes that are the cells that configure the myocardial walls. And as we get older, two things happen. Our vessel walls become more thick, and our cardiomyocytes become hypertrophied. And so that myocardial wall becomes thicker. And just because those look bigger doesn't mean they work as well. Typically, when something is more enlarged like this, there's fewer of those cells and they just don't work as well. So that muscle strength, the stretch, all of those things aren't as effective as they once were. Because the cardiac system is so important, we can also see we can have a lot of other problems that we might have. We could have a narrow valve that's not letting enough blood flow through. We could have a leaky valve where the valve isn't closing quite properly and the blood leaks backwards. We could also have a ventricular septal defect where we're going to mix oxygen-rich blood with oxygen-poor blood. And then we're going to have a much more effective body system overall. Other things in our arteries that happen, our arteries become more thick. We develop plaque and inflammation and calcium deposits. The vessel walls become more stiff. So when someone's in their 20s, their arteries are pretty healthy and clear, but we can see that this processes have already begun, and we're already starting to see a buildup and a thickening of those walls. In your 30s and 40s, those fatty deposits begin to gather. Women are pretty protected until menopause, but it's much more accelerated in men. And if cholesterol levels are high, then or you have high blood pressure, that exacerbates that issue. In your 50s, the plaque builds up even more. The vessels walls become more stiff. Hypertension causes more damage. We could have scarring and plaque buildup. And by the time you're in your 60s, we've had so many heartbeats per day. All of those are building up, and that daily impact is affecting how your blood vessels are able to transport blood. And that artery damage can either be prevented or reduced by regular exercise, a healthy diet, and not smoking. It can definitely be exacerbated by poor exercise, poor diet, and smoking. Presbycardia is the word that is used to describe an impairment of cardiac function due to aging processes, and it indicates a reduced cardiac reserve. And then you can see here that we have a much smaller space within to collect blood, so we can't get as much blood into the ventricles, and that means we have much less blood to send out to the rest of the body. So we'll have a decreased maximum heart rate, stroke volume, cardiac output, and ejection fraction. And that means that our myocardial oxygen uptake, or how much oxygen all of these cells need, is now increased. These cells are much larger. They need more oxygen and nutrients in order to function well. And we're putting a much stronger demand to try to get just as much blood out to the body that we always have had. And the heart muscle has a hard time keeping up with that. Another abnormal sign is the fourth heart sound. Now, we can have a fourth heart sound. It typically occurs when the left ventricle is filling and when the atrial contraction forces blood into a non-compliant left ventricle. So the atria is pushing blood into the left ventricle. The left ventricle doesn't really expand like it normally would, and so we get this S4 sound saying there's a problem in here. And it is a sign of diastolic heart failure, and very rarely would it be a normal finding. So there is a nice website here for heart sounds if you want to review that. And then S3 can be normal. Remember, S4 is not normal. S3 is early in diastole. It occurs during passive left ventricle filling. It can be normal, but the left ventricle has to be working. It needs to be compliant. It has to expand. And S3 typically is a sign of congestive heart failure. S4 gallops are a sign of occur in late diastole. They occur in active left ventricular filling. It's almost always abnormal, and it requires a non-compliant left ventricle. And it's certainly a sign of diastolic congestive heart failure, which is a more severe condition than systolic congestive heart failure. So what does this really mean for gerontological nursing? Well, basically it means that how younger people compensate due to stress, infection, whatever. And in an older adult, those conditions will be more blunted. The heart rate won't increase as dramatically as it does in a young person if you have a fever. So our older adults may not seem as ill. They may not seem as in distress until they crash. And you need to have a very diligent nursing assessment to prevent that rapid decompensation or that crash and code situation in a person who's much more frail. For the respiratory system, we have three main things that happen. Decreased cilia, enlargement of the alveolar duct, sorry that's misspelled, and prolonged expiratory time. The decreased cilia occurs due to age. We don't keep them up as well. We don't create new cilia when we need them. What that means is that our patients will have less surface area for gas exchange, and they'll have a decreased respiratory effort. So they won't take as deep a breaths, or they won't speed their breathing in order to compensate as much. The enlargement of the alveolar duct increases the residual volume, so I have more oxygen left in my lungs on exhalation. It decreases the tidal volume, and it decreases the ventilation to perfusion ratio. So I'm not going to move as much oxygen and carbon dioxide back and forth through the system. And then the prolonged expiratory time, that happens because I'm trying to get rid of that extra residual volume. But in the end, what happens is that it decreases the response to hypoxia and hypercapnia. So I still can be hypoxic, but I may not look like I'm in distress yet until we hit that total decompensation time frame. Key respiratory changes. Our patients are going to have poor gas exchange because their chest wall is more stiff, their diaphragm is more weak, they have a decreased basilar inflation and hyperinflation of the lung apexes, so we can't get as good of inflation, and we can't get rid of that residual volume, and so our lung apices are overfilled. We have a decreased alveolar surface area. They don't respond to hypercapnia and hypoxia as well, and this all results in that decreased vital capacity. They're also less able to handle secretions because they have a diminished cough reflex. The secretions are more tenacious, and the decreased number of cilia don't help to promote those secretions to move up and out of the system. And that results in an increased risk of infection and pneumonia. For the renal system, there are quite a number of changes that happen in the renal system, but we're going to pull it right down to this circle on this slide. Basically, what you need to know is that the glomerular filtration is decreased in the renal system, and the AVP concentrating effect is decreased. So that's your big points for the renal system, is the glomerular filtration is decreased. Our patients will not excrete as much fluid as effectively. Our kidneys just aren't working quite as effectively as they could at eliminating waste products. That overall effect means that our patients and residents are more apt or prone to dehydration due to that decreased urine concentrating ability and decreased thirst mechanism. That thirst mechanism comes into place way up here when we are releasing different hormones like renin, aldosterone, and atrial natriuretic hormone to normally to promote thirst, but because those are so very much decreased, our residents no longer have that thirst mechanism, and we have to remind them to drink. We also know that creatinine clearance gradually decreases with age, and by the time our patients are around 75, it's decreased by more than 40 points. And so we can estimate what a good creatinine clearance is for our residents. In order to do that, we also need to know gender and weight. And we'll have there it is, the creatinine clearance formula. You don't need to memorize this formula. If I was going to ask you about it, I would provide the formula for you and also a calculator to use on the quiz or exam. But you basically take 140, which is the normal creatinine clearance, you subtract their age, take it times their weight in kilograms, divide that by 72 times the serum creatinine level, and then if they're female, you take that times 0.85. If they're male, you don't have that extra number to use to multiply by. So the key changes for the renal system is that decreased glomerular filtration rate, decreased creatinine clearance. They don't concentrate urine as well. They don't tolerate hyper and hypovolemia. If they have hypovolemia, they surely have renal insufficiency. So you might see hyperkalemia and increased creatinine levels. They also have a potential for dehydration because of the increased or decreased urine concentrating ability and that decreased thirst mechanism. These changes are pretty important, and we need to really watch for renal toxic medication, excessively warm temperatures, and inadequate fluid intake. And so hydration programs are one of the most essential things we can do for older adults. If we can keep them hydrated, then we see much lower rates of delirium, urinary tract infections, and other conditions. So that hydration is pretty key intervention for older adults, especially those in facilities. The endocrine system also will have decreases, so the adrenaline gland becomes more fibrous, and all of those glucocorticoids, progesterone, estrogen, androgen are decreased. The ACTH is also decreased. We have delayed and insufficient release of insulin, and also decreased tissue sensitivity to insulin. That means that it's not abnormal for our residents to have, or hospitalized older adults, to have a elevated blood glucose level, even if they're not diabetic. But these changes in their endocrine system make it quite easy for their sugars to be high. You also should take a look at individuals who start to show changes in cognition after eating higher carb type foods. Like, for example, at Tiger Place, one of the residents always liked to have orange soda about 4 o'clock and a little snack to get him through till dinner. Usually that snack was a cookie or a little piece of chocolate. And for a while, they started seeing that he was getting really confused shortly after he ate those. Well, his blood sugar was going through the roof. They checked for a urinary tract infection, and he was actually spilling sugar into his urine. So his blood sugar was quite high. And then once they identified that and helped him understand what was going on, then they made a change to those habits that he had, and that confusion went away. So you have to be alert for those types of things and start to be a good detective to piece and puzzle things together to figure out what the problem might be. In the digestive system, the teeth lose enamel. They become more vulnerable to tooth decay. If they have dentures and they don't fit well, which is frequently the case, they can contribute to problems. I've seen residents who had food packed up underneath their dentures and didn't realize it. That led to a lot of oral lesions. Their gums are more susceptible to periodontal disease. Their gastric acid secretion is altered, and because their endocrine function's slow, then we also see vitamin B12 absorption is disrupted. We can see osteoporotic changes that threaten tooth root integrity. Teeth can break, and our patients have dry mouth because the saliva production has been decreased by at least 2/3. We also want to talk about all the different sites that interfere with the release of vitamin B12. So we're seeing that we have that decreased stomach acid, lots of drugs that people can buy over the counter like H2 blockers and plasma protein inhibitors, gastrectomies, anyone who's had gastric bypass, atrophic gastritis, pernicious anemia, all of those things cause lack of intrinsic factor. So that doesn't really interfere with the release of vitamin B12, but it definitely impacts the ability to absorb vitamin B12. The pancreas is working in an insufficient manner, so it decreases the secretion of pancreatic enzyme, which is actually what releases vitamin B12. Bacterial overgrowth decreases the amount available for absorption, the amount of vitamin B12 for absorption. We have interference with plasma transport, and then other drugs like metformin and Questran interfere with absorption. So we have a lot of different areas where vitamin B12 can be impacted because of aging, and that is why many older adults have issues with low levels of vitamin B12 in their system.